All right, we are just about 3 minutes after, and we have a packed agenda for you guys. So I would love to get us started. So, good morning, good afternoon, and good evening. Welcome to the Perinatal Mental Health 101 webinar. My name is Makiba Charles Ayende, and I am the co chair for the Non Communicable Disease or NCD Working Group for the Global Health Council, as well as the Director of Science Policy with the International Association for Dental, Oral, and Craniofacial Research. So I'm happy to see so many of you here. Please feel free to introduce yourselves in the chat. Some of you have already started doing that, so thank you for that. The Global Health Council is the leading member organization that is devoted to advancing global health priorities by uniting advocates, implementers, policymakers, and other stakeholders. As part of the advocacy efforts, GHC hosts member only advocacy working groups that connect people and organizations that are passionate about global health with resources and opportunities to take action and make a difference. Our NCD working group unites organizations that are focused on improving care for people living with NCDs, including groups that focus on community health workers, mental health, clinical support, direct care, and patient and family support. We bring together a range of NCDs, including cancer, heart disease, oral health diseases, childhood onset NCDs, and more. Our working group is currently focused on educating and building awareness around NCDs among the United States government and multilateral agencies, building awareness around the investment case for NCDs among multilateral agencies, including how much money could be saved with prevention, early diagnosis, timely treatment, etc., and aligning the larger NCD community around engagement with the 2025 UN high-level meeting on NCDs. One of the key areas that we focus on at GHC, IADR, and a number of GHC member organizations is mental health. The purpose of today's webinar is to provide an overview of the burden of perinatal mental health globally and highlight national efforts to optimize perinatal mental health care, especially in the lead up to the HLM on NCDs that will happen later this year. So we will begin with a presentation about perinatal mental health, an overview of that, as well as an outline of the project on perinatal mental health advocacy by the United for Global Mental Health. And we will have a series of short presentations from leaders and persons with lived experience within this space. And of course, we will give you the opportunity to ask your questions. And I encourage you to challenge our presenters. This is a safe space for that. Feel free to add your questions at any point to the Q&A box so that we can address them during that Q&A session, or we will try to answer those questions as we go along as well. So before we dive in, I would be remiss if I don't say that we're coming together at a pivotal time for global health. We are seeing declining investments, fractured commitments, and the deprioritization of essential global health agendas. These changes we know have far-reaching consequences, particularly for vulnerable populations, and they threaten hard-won progress in NCD prevention and areas like maternal and mental health. And this is why our continued advocacy, especially now, is so critical. Our collective work must continue to advance policy and drive innovation in how we support mental health, during pregnancy and the postpartum period. Today, we're here to learn, to listen, to connect, and to recommit ourselves to building a future where perinatal mental health is treated not as an afterthought, but as a cornerstone of maternal and child health. And to help with those efforts, this webinar will be recorded and we will share, including all the PowerPoints that you will see today. So I want to thank you again for being here to be a part of this important dialogue. So on that note, it is my privilege to introduce Dr. Alan Gregoire, consultant specialist and perinatal psychiatrist and founder of the Global Alliance for Maternal Mental Health. Dr. Gregoire, over to you.
Thank you very much indeed. And it's a huge pleasure to be here with this fantastic gathering of people to discuss, as you said, this incredibly important topic, not just to individuals affected, but to the whole of society, and reflecting our attitudes as societies and as humanity to suffering caused by mental health problems, but also our attitudes to women and our attitudes to children and to young families on whom we depend for bringing up and creating the next generation and therefore our futures. And there is nothing more important in that incredibly difficult task, the most difficult thing we humans ever do, of nurturing the very young who will become the future members of our societies. So I've been tasked to very, very quickly give an overview of perinatal mental health difficulties and challenges, and the opportunities that offers for really amazing advances. And these are opportunities that are offered by science, and these are opportunities which we are the first generation of humans to know about and to be able to be offered the chance to embrace. So as a first introductory slide, let's just consider this concept of depression, quite a broad concept, and sometimes considered together with anxiety difficulties and other significantly disabling forms of mental health suffering. So if we consider the relatively tight definition of depression, measured in countries throughout the world, both high income and low and middle income countries, during the perinatal period, what you can see is that depression is by far the most common major health complication of maternity throughout the world. And actually, this graph represents an underrepresentation, a very conservative estimate, because the figures for depression are those of point prevalence figures. In other words, depression in this population of women in pregnancy and postnatally measured at a single point, whereas all the other health complications in this figure are those measured throughout the perinatal period. Now, of course, some of them occur at a particular time, but depression occurs throughout. And the numbers of women affected are in fact considerably higher. In many countries, that period prevalence, the whole of maternity, the pregnancy and postnatal period, gives us figures of 30 to 50% of women suffering from significant disabling. By definition, mental health conditions are disabling, disabling depression. So a very, very common problem. And I don't have time to show you the slides to demonstrate this, but a hugely represented problem in terms of action, but even in terms of recognition. Women with these difficulties, despite most women in the world having access to some form of maternity health care, depression is hugely unrecognized. The majority of women throughout the world with depression go unrecognized by any services or indeed those people around them supporting them. And if we doubt that depression is a serious health complication, we only have to consider the WHO's statistics on burden of disease, so life years lost through death and disability, premature death and disability, in women of childbearing age, in both low and middle income countries and in high income countries. Depressive illness tops the bill of all health conditions known to man in terms of life years lost through premature death and disability. And of course, we have to remember that we're talking about young women here and a very serious disabling condition. If we look at the most disabling conditions that we see in mental health, psychotic illnesses, we have evidence now from studies in various parts of the world that there is no other time in human existence when you are at such high risk of becoming psychotic as in the first few days and weeks after childbirth. In either men or women, there is no other time of such high risk. And of course, this only happens in women just after birth. So both the most common health complication, but also the most common time for having very, very severe health and disabling and life-threatening health conditions. And yet, this is a time when women are in contact with health services throughout the world. We've made huge strides in maternity care, but that focus, purely because of tradition, and I would say discrimination against mental health and those people who suffer as a result of poor mental health, the developments in maternity care, fantastic though they are, that have happened throughout the world in high and low and middle income countries, have focused on physical health. And that discrimination, that lack of parity between our mental well-being, which after all is what makes us the individuals we are and makes us the species, the successful, although yes, sometimes we might doubt our success on this planet, but makes us the species that we are, our mental functioning is hugely neglected relative to the understandably relatively simple aspects of physical health and physical health care. And you can see from this graph, yes, this is done in a high-income country in London, but the findings look pretty similar in studies throughout the world. If you're looking for a time of highest risk for suffering from depression, pregnancy is the best moment to be detecting, both in terms of opportunity because of contact with healthcare, but also because this is a very common time when depression starts in the lives of young women. And I've spoken about the challenges and the opportunities, of course, that these difficulties present us amongst women having children, but the impact is also very well documented of mental health problems in mothers during pregnancy and postnatally, particularly on the development of children. And we have studies now, and I'm showing here a slide relating to low and middle income countries. We have studies showing very clearly relationship with poor antenatal care, reduced breastfeeding, malnutrition, and stunted growth. So really the severe end of impact on child physical development, as well as impacts on a variety of measures of physical health, and psychological and behavioral and cognitive development in children, which without intervention, without sustained intervention, without universal intervention, clearly has ongoing effects on the development of children for years and years and years. And these studies are really consistent across low and middle income countries and indeed in high income countries. Yet, I keep saying it, huge challenges, but fantastic opportunities, because we also know that intervention, realistic intervention in the context of both high-income countries and low and middle income countries is absolutely possible. So we now have a fairly extensive literature. We have models of care. We even have international guidance, and we have adapted interventions to economic and cultural contexts. So there is really no excuse for not grasping this opportunity apart from discrimination against mental health in these sorts of settings. And of course, yes, there are lots of practical problems to overcome, just as there are with trying to develop physical health interventions, but these are all possible to overcome at large scale if there is a will to do so. And so we have research evidence, we have guidance and policy, but the reality is we have little national action. And just while we're on this slide, I would particularly emphasize that center document there, the Guide for Integration of Perinatal Mental Health Care into Maternal and Child Health Services, published relatively recently by the WHO, pointing out how to go about doing things. Just in the last couple of slides, looking at a global perspective on this, you can see here that we've been trying to collect at the Global Alliance for Maternal Mental Health, we've been trying to collect data on published policies available on the internet from governments in countries around the world on maternal and perinatal mental health. And what you can see in green is where there is dedicated specific policy. And what you can see there is that there are high-income countries who've managed to produce policies, national government policies, and there are low and middle-income countries that have managed to produce national government policies. And interestingly, there is quite a match between those countries that have done this and those that have done research in the area and who have done economic research. The economic research, of course, showing that this is a huge economic burden that we really should be taking action on as an investment in our future human infrastructure. So there we have it. We have international policy in this area. We have some national policy, and national policy is absolutely possible. But we only have examples of national strategic action across populations in those areas where people and organizations have come together to advocate for perinatal mental health. This is not an obvious top of the list for governments. Most governments don't know the research, don't know the guidance, and it requires advocacy, but also concerted efforts by organizations within countries coming together to both take action and demand action at a national level. And where that happens, we are starting to see alliances of organizations having an impact at national level. So to finish, I'd just like to say that please come together, you who are who know this, have this knowledge, who see this opportunity, come together, unite, agree objectives, develop expertise in your country, and demand change, ambitious change. And the Global Alliance is there to help you do that. And I finish with the words of Nelson Mandela: vision without action is merely a dream, and action without vision is merely passing time. But in perinatal mental health, we have the opportunity for both. So vision with action can change the world. Thank you.
Thank you so much, Dr. Gregoire. That was fantastic. I thank you for pointing out the challenges that we have, but also the opportunities for evidence-based action to move forward those national agendas. So thank you for that. So with that, I want to hand over to our next speaker, Dr. Hamdi Issa, who is the Senior Policy and Advocacy Officer with the United for Global Mental Health. Dr. Issa, over to you.
Thank you for that introduction, Makiba. Thank you to everyone for joining us in this webinar. It's exciting to see so many of us invested in this very important global health issue. As a way of introduction, United for Global Mental Health is a charity that focuses on advocacy to catalyze mental health as a global issue. Our strategy is guided by 4 main pillars. Under our pillar for improving mental health care systems, I lead our workforce portfolio, where our goal is for a well-resourced health workforce that can deliver mental health services across healthcare systems. Within this portfolio, we're leading a project on advocacy in perinatal mental health. Now, Dr. Elaine provided a great overview of where we're at globally with perinatal mental health. I would like to just stress that the discrepancy between the burden of mental health conditions and the availability of an adequate mental health workforce is extreme in low-income settings. In many parts of the world, mental health is notably absent from maternal, newborn, child, and adolescent health services. The limited availability of early intervention maternal mental health services, coupled with this chronic global mental health workforce shortages, increases the likelihood of an inadequate detection of and availability of early intervention for maternal mental health conditions, forcing new parents, especially young mothers, to navigate this period alone, often with limited economic resources. Therefore, at United, we're working with our national partners to advocate for governments, donors, and decision makers to strengthen the perinatal mental health skills and knowledge in the existing health workforce to transform care for mothers, especially young mothers and their newborns. Our project is working towards this vision through 3 main pillars. First, increasing visibility. So across many countries, we know there is a lack of adequate perinatal mental health care available to mothers, especially young mothers, as Dr. Elaine has outlined. We're using different mediums, such as the webinar like this one, and the presence at global conferences like Conference of Public Health in Africa, the World Health Assembly, social media campaigns to really promote key advocacy messages, spotlight the contributions of our frontline workers and the voices of women with lived experience to reimagine a new way forward for decision makers to better support women during the perinatal period. Second, contributing to the existing evidence base. We understand and appreciate that there is ample existing evidence and normative guidance on perinatal mental health and its integration into maternal and child health services. However, we also recognize that information is not always accessible and digestible to governments and donors on the ground. Therefore, in this policy brief, we're working closely with our national partners to curate context-specific key advocacy messages and showcase examples of best practice being led by national partners to present the case for strengthening the capacity of the existing health workforce in perinatal mental health knowledge in a manner that is relatable and digestible to national governments and their development partners. And last but not least, supporting advocates. Later in the year, we'll be working closely with national partners to develop a peer-led virtual workshop to support national partners deliver strong youth-led or person with lived experience advocacy messages on perinatal mental health, to raise awareness, but also have the language to influence national policy that shapes the care available to mothers. So that's sort of a quick overview of how at United, we're using the power of joint advocacy to drive action amongst governments and development partners in increasing investment in training of the workforce in perinatal mental health skills and investing in scaling up examples of best practice to transform perinatal mental health care. In our advocacy efforts, however, it's important that we remain cognizant of the current development architecture we are operating. In this period, we recognize and appreciate the unprecedented global reductions in foreign aid are hitting hardest fragile countries that rely heavily on donor-funded health programs. These cuts threaten the progress countries have made towards maternal health and the ambitions for strengthening maternal mental health care. This threat on maternal health is highlighted in today's WHO joint press release. Access to quality maternal health services, inclusive of mental health, is a right, not a privilege. Therefore, it's crucial national governments continue to prioritize domestic investment in maternal mental health. As an organization, we look forward to continuing to find new opportunities and engaging with different partners to advocate for the prioritization of funding for perinatal mental health, to strengthen training for the health workforce, and ensure quality integrated perinatal mental health care that is available and accessible at primary and community levels too. So that's an overview of the work that we're doing at United. I look forward to listening to the experts on the ground who are talking about creating change and thinking about how can we learn from these examples of best practice. Thank you, Makiba.
Thank you so much, Dr. Issa. And thank you for sharing some of the details of your advocacy project. If you would like to connect with United, please reach out to Dr. Issa so that we can have a really clear collaborative effort going forward. Okay, great. So now we're going to move forward to our next presenter, who will be Dr. Moses Zia. Dr. Moses is the director of the mental health unit within the Ministry of Health in Liberia. Dr. Zia, over to you. Dr. Zia, are you able to, oh, there we go. Thank you.
Well, good afternoon, good morning, good evening to everyone. I'm happy to be here. As introduced, second, I'm a psychiatrist and I'm joining from Liberia. I'll be sharing with you overview of what we are doing here in Liberia. So this is just a quick presentation and I will be taking you through. Liberia, Liberia is a small nation in Africa, West Africa specifically, with a population of about 5.2 million people. A small nation, but has had wars spanning up to 20 years, and of course, significant outbreak like the Ebola outbreak, and of course, the COVID-19. So this small nation has had to deal with a lot of issues with significant mental health complications. So for mental health care, I would like to give a general overview of our mental health services. So mental health care started many years ago. And so like many other countries, before conventional practice could come into being, there were mostly non-conventional means of doing things. So there were traditional healers and faith-based healers who provided care. So before our civil wars in Liberia, those were the main people providing care before the 1960s. Up to the 1960s, we got the first rehabilitation center, the first treatment center constructed, but unfortunately it was destroyed. So after the war, that facility was destroyed, and of course, services being provided for mental health disorders still remain to be provided by traditional and faith-based healers. But then after the facility got destroyed of late, we were able to have additional facility built, but it's a smaller facility. So that's just a quick overview. Our mental health service provision came into our national policy when we had the essential package for health services, which then came into being around 2009, 2008, 2009. So our first mental health policy was developed in 2010, the second policy 2016, and eventually we've had a third mental health policy, which is the most current revision. So mental health vision came into being as a result of those policies. So in recent policy guidelines, it is clear that mental health services should be provided according or along the lifespan. So those services include from birth up to late adulthood. So that is how our mental health services have been arranged using these policies. The most recent policy being the third national mental health policy and strategic plan. Speaking about workforce, until 2016, Liberia had just one psychiatrist, Professor Benjamin L. Harris. After 2016, we got one additional psychiatrist who joined for the postgraduate training program, which actually started in 2019. And so up to about between 2022 now and 2025, we have 10 psychiatrists in country. So you imagine a country of 5.2 million people having just 10 psychiatrists. Definitely the care cannot be provided to everyone, and because of the area these people are assigned as well. So through our major mental health partner, the Carter Center, we were able to, as a country, several mental health clinicians, and these are mid-level clinicians, the nurses and physician assistants who receive specialized, who receive basic training rather, to provide mental health services. So the training services. So, 368 of those people were trained. As a country, we have 6 psychologists in country, but there's only one in the employed of the government at this time. And this one just came in. All the others are in private practice and with NGOs. So in terms of mental health or service integration, our mental health policy and strategic plan has specific objectives, and objective 2 clearly states that we should reduce stigma and discrimination against persons with mental illness by integrating by integrating mental health into other health programs. So as you see right here, we've had a lot of integration work happening. And all the ones you see look green, we've had initial work, at least pilot phase of integration work happening. And those ones that are yellow, we've now had a clear pilot, or we've now had a clear program developed. So the child health unit is a newly established unit out of the family health division. So here, the family health division is the major unit with which we work as it relates to mental health or perinatal mental health integration. So specifically, our experience with perinatal mental health started with a project enrolled by the Carter Center, and this project happened between 2020 and 2021, and it was about enhancing maternal mental health and well-being in Liberia, and it was based on the Thinking Healthy program. So this program was adapted for Liberia with modifications from the original program that was established by Dr. Najjar Atif in Pakistan. Fortunately for us, this pilot phase of this project actually was able to get Dr. Najjar herself in Liberia, and then we implemented it for like 2 years. So the major outcome of the program was that we had training for master trainers, like 17 master trainers were trained, and eventually we trained about 240 healthcare workers. Knowing that the Thinking Healthy program is mostly focused on depression, we were able to conduct training using the PHQ, how we have healthcare workers using the PHQ to screen for depression, perinatal depression. So using this method, we were able to provide this intervention to about almost 4,000 people, women and infants. So from the Thinking Healthy program, we now was able to go forward using that model to do a lot of integration work. So we have integration work going on with the National Community Health Program, and this is a massive program we have in Liberia. So activities that are currently ongoing, we have integrated Big Belly book, as we call it. And this book is a simple book printed and given to pregnant women and new mothers to be able to identify common mental health conditions, including psychosis, depression, and anxiety, and others. So we are able to train community health workers to be able to identify perinatal issues among people, among patients, and be able to refer. Then recently we had a family health division integration wherein we are able to train midwives to be able to identify common perinatal conditions and be able to refer. So basically, this is our journey. We're still going ahead. The major challenges we've had along the line include a set of staff or a set of providers and then they have to leave practice or they have to be reassigned, then it causes problem. The issue about limited workforce, as you heard about workforce, is still a problem. We do not have adequate service providers. And of course, using the Thinking Healthy model, clearly we know that it's a structured program. Unfortunately, training for the structural psychological intervention. So for now, we can easily be able to identify, the conditions, able to refer to service providers. So that is it. This is really brief. Thank you for having me.
Thank you so much, Dr. Zia. We appreciate you sharing an update about progress within Liberia in this space. I'd like to hand over to our next speaker, Dr. Estelle Seeds, who leads the research portfolio on maternal, newborn, and child health, and the portfolio on adolescent and maternal mental health in the African Population and Health Research Center. Dr. Seeds, over to you.
Good morning, everyone. Good afternoon. I'm happy to be here. Dr. Sizi has presented. I work at the African Population and Health Research Center, which is an NGO research center based in Nairobi, Kenya, and where we work on transforming lives in Africa through research. And as mentioned, I lead the portfolio on maternal mental health at the center. And what we do specifically at the center, we want to make maternal and mental health care a reality on the continent for mothers. And we do that by doing research, but also engaging policymakers across different countries, including Kenya. And what we want is to really gather evidence around who is most at risk in terms of maternal mental depression and all the other conditions, but also why are they at risk in terms of risk factors, but also what are some of those solutions that can be put in place to help those mothers navigate through the postpartum period and taking care of themselves and their family. And one population that we focus most also within my team is adolescent and young mother. And adolescent and young mothers, we know that when we talk about maternal and child health care in general, it is a marginalized population. We know that adolescent pregnancy is sometimes stigmatized within environment. So in terms of access and quality of care given to young and adolescent mothers, we sometimes have a number of challenges and barriers that those adolescents and mothers encounter. And also, when it comes to maternal mental health, you can easily understand that those mothers, because they're already stigmatized for being pregnant, they really have difficulties in terms of expressing themselves when they feel that they have emotional troubles or they can't navigate through the postpartum period efficiently. So what do we try to do with this project that I'm presenting today, the Sasa Mama Teen project? Sasa Mama Teen is in Swahili. It means how are you doing, adolescent mother, Sasa Mama. And what we tried to do with this project was really to give a voice to adolescent and young mothers. So really lived experiences to give them an opportunity or platform to express themselves, talk about what they're feeling, the lived experiences through the postpartum period, but also give them a platform where they can, with us, design solutions that are youth-friendly, adolescent-friendly, that we can implement with the help. So the main objective of this project was to work with 150 adolescent mothers in the slums of Nairobi to design, to co-design, and to test a toolkit of information, skills, and that we wanted to use to shield them against stress during the pregnancy and the postpartum period. And the vision that we have, of course, was stronger minds for stronger adolescents in Nairobi slums. We were privileged to receive funding from Grand Challenges Exploration for this project. And this really gave us an opportunity to engage adolescents and hear what they want us to do as researchers, as policymakers, and all stakeholders. So yeah, I'm just presenting quickly the toolkit that we were able to develop. And this toolkit was based, as I say, from information and that we received from adolescents around their lived experiences and what they want us to develop in terms of solution. In terms of the landscape on the maternal mental health needs and challenges of adolescents, we've also gathered some evidence and we published a paper. I think the link will be shared with you. You can consult the paper. And what I just present here is basically the toolkit contains. And if you see the toolkit, we know there are a number of toolkits that exist, especially those developed by WHO to be used in community. But we wanted a toolkit that, as I said at the beginning, that is adolescent or youth mothers friendly. And we wanted the toolkit to be informed by their own needs. And if you see what we focus on, especially in the section 3 of the toolkit, we focus on information sharing. Because one of the critical things that adolescents and young mothers told us is that they have to navigate in a space where they don't have information on maternal and child health in general. They don't know where to access service antenatal. They're ostracized in those maternity services. They know that there are free services available within the country in Kenya, but they don't know how to access it, how to register. So just that creates a huge deal for them and a huge source of stress for them. So we made sure to include that section within the toolkit, really information sharing on all of those basic needs or information needs for those adolescent and young mothers. And the next section, section 4 of that toolkit, is really around confidence building, because what we also understood is that the skills that they needed the most was confidence building, how to build the confidence in the midst of the chaos, being discriminated, being chased from the house from some of them, being forced to get an abortion for some of them, and for some of them also feeling like the lives have ended. They don't have future anymore because of that pregnancy. So really how to build confidence and how to help them being able to navigate this challenging time of pregnancy and still become, strong mothers and take care of themselves and their families. For the toolkits we developed, and we also test the toolkit. We test the toolkit through a field experiment with 100 adolescents that we randomized into 2 intervention groups. So there were one face-to-face session that we provided over a period of 3 months, 12 sessions, confidence building, and we added some classes around yoga. And we also had a second group, we randomized group that we did interventions with WhatsApp group. So we did the same. The 2 interventions were similar in the 2 platforms, and then we compared the degree, the perception, or the satisfaction of those participants on these 2 channels that we use. And we were overwhelmingly made aware that the WhatsApp group were actually the preferred mode for interventions for confidence building. And then the reasons that adolescent gave is because it gives an opportunity to have a community of women that they can talk to, they can discuss other things than just the daily lives, the mental stress and daily lives, but they can talk to, they can encourage each other. So it's really, I think, for us, emphasizing why it's important perhaps to also have interventions for adolescent and young mothers that are on digital platforms like WhatsApp and other. But what I also wanted to highlight very quickly here is really what we achieve with this project, because it's very important for the community of practice working on these issues, especially for adolescent and young mothers. The first thing is that we realized that the project was an incredible platform for those mothers to just talk about mental health. Or when we gathered the 150 women in the slums of Nairobi, we realized when we implemented this project, we quickly realized, and they told us that this is actually the first time that somebody come and sit with us and ask us to speak about mental health. And for a lot of them, they didn't even know what mental health means. We had to do an assessment of their mental health state at the beginning of the intervention. And we quickly realized that even the tool that we use, the EPDS tool that we use, even if you use a translated one in Kiswahili, was not a tool that was easily understandable by adolescents. So we really have to pay attention to that also. How do we maximize on improving those tools for measurement for mental health? Among adolescent and young women, they had a lot of difficulty understanding some of the questions that were posed within the APDS tool. And then the second thing that I also want to really highlight here is the fact that the needs for mental health care are tremendously high among those adolescent and young mothers in the slums of Nairobi. very high. And as I say, a lot of them actually explore. When we did the assessment using the River of Life, we realized actually that some of them had suicide ideation, and which is something that we think is really critical in terms of intervention. So we really have to pay attention to the needs, mental health needs of those mothers. And I also mentioned the River of Life. River of Life introduced the River of Life because we really wanted a tool that will work best for adolescent mothers, because as I say, the APDS did not really give us very strong results. And you can have perhaps also a link on what the River of Life is, but it's just a tool for adolescents. We provide them the paper and pens to be able to draw the life as a river and to tell us significant events that have happened during the course of the life of the river. And to tell us actually what are the major sources of stress within that river, but also where do they find themselves. And it was really a very nice tool for them to use. And with the help of psychiatrists from the Kenyatta Hospital, we're able to interpret those documents that we received from them, and to refer the girl for appropriate treatment for those who needed treatment. So again, for me, I think here is really to thank the fund that will give us opportunity to be able to have this dialogue with adolescent and young mothers, and to really help us also navigate through the type of solutions that we can bring for them, and also perhaps join maybe the rest of the panelists in terms of this plea of making maternal mental health a reality, especially for young and adolescent girls in Africa. Thank you.
Thank you so much, Dr. Seeds. I want to point out to everyone that in the chat, there are links to the toolkit that was developed through this project, as well as a publication. So now I want to hand over to our next speaker, who is Sifi Andina, who is the non-executive chairwoman of the FMCH Indonesia. So Sifi, over to you.
Thanks, Makiba. You can call me Dina, easier to pronounce. Hello, everyone. I'm calling in from Jakarta, Indonesia. What I will be sharing is our initiatives in the foundations. We've been working on maternal mental health for the past 3 to 4 years. But the foundations itself have been, operating and doing program for mother and child health for more than almost 25 years now. But in the recent years, we began to realize the needs around maternal mental health. We've been doing webinar, we've been engaging with different organizations, including with local authority in the rural area where we work. But we found that nothing really attract their attentions when we spoke about maternal mental health. While we know for sure there is an issue, because we've been interacting with these mothers in our health and nutrition programming. So we decided to start collecting data or evidence from the primary resources, from the mothers themselves. We believe that mental health data is essential. It will help us to make the invisible to be visible, and also to bringing critical issues around, like depressions, anxiety, trauma, to be a focus in our health system in Indonesia, and also for the policymakers, but also for donors or community at large. And we found that without data, unfortunately, without data, specific data in the region where we work, it's becoming even more difficult to attract their attentions. But also, we found that there is a lot of undetected case until it's just too late. And then also, we believe that with robust data, it will help to identify early identifications of problems, and also it will help to provide a more targeted support for mothers. And for us at the foundations, it is also will help us to design interventions around mental health. And we believe that without data, we cannot really improve our program, because most of the health for pregnant women, for lactating mothers, is around the physical health, but not really for the mental health. While Indonesia, we're still facing problems around stunting, and mental health is something that haven't really been taught by the government or like by many of the player around health and nutrition issues in Indonesia. So yeah, like I said, unfortunately in Indonesia we don't have a specific and primary data for maternal perinatal mental health, despite increasing cases, not only in rural area, but also in the urban area in Indonesia around, postpartum depressions, even suicide. So we decided to run at the foundations, we decided to run a micro research in 2 rural areas, in 2 districts in Indonesia. We have around 200 pregnant mothers and lactating mothers participated in the survey, and we use the SRQ questionnaire developed by WHO to assess mental health conditions, not specifically for pregnant mothers, but that's the instruments that we use to assess general conditions. But then we use it for the pregnant and lactating mothers. The assessment place those mothers into 4 categories. One is the normal categories, meaning there's no symptoms of mental health issues. And then the second category is PTSD, post-traumatic syndrome disorder, depressions, and psychotic disorder. So the assessment placed them into 4 categories, and it is also we have around 28 questions to assess the mental health status. And what we found, surprisingly, only 4% of those mothers indicating that they have normal or no symptoms of mental health issue, while the rest of the mothers falls under either PTSD, depressions, or psychotic disorders. And our observations during data collections, we thought that those mothers are looking okay, like they look okay. Even the midwives who came with us and the community health worker who helped us to interact with the mothers to collect the data also, like expected, there's no big issues on mental health. But when we share the analysis, it shocked them. Like they did not expect high level of mental health issues among these mothers in these regions. We tried to find the reason why this is happening through the survey, but also engaging with the family member, husbands, the in-laws, the mothers of the grandmothers, and also interviewing midwives and community health worker. We found that the domestic household chores is a burden. Also, gender stereotyping is also a big problem. And for the mother themselves, they feels like the economic burdens or the situations of the family economics is what stressing them. But also we found that husband and there's lack of support or understanding from the husbands and the family. And unfortunately, the midwives, not all of the midwives in the locations where we collect the data have been trained. From 14 midwives, meaning in 14 communities, only 1 that have been trained on maternal mental health, while the primary contact that this mother have is the community health worker, and none of them have been trained on this maternal mental health. So this data, from this micro research for us is tools to advocate for more support and attentions to the mental health conditions. The data that we collected was in a high stunting prevalence regions in Indonesia. So we shared the data with local governments, but also at national level, we collaborate with our peer organizations through Maternal Mental Health Alliance in Indonesia. We are advocating to collect more data on maternal mental health, like primary data, and to see the data not just as a statistic, but as a lifeline to help mothers and to make the invisible to be visible. And for us at the foundations, we are begin to develop training module for the community health volunteer, using the finding from this micro research as our basis, but we need reference from other who might have developed something for the community worker, because for the midwife, the government has already provide training, but it's not easy to access for midwife, but we are developing something for the community worker. And I've listening from Liberia, there is a module that you develop for the community health worker. So please share with me if you have anything for the community health worker to support maternal mental health. Thank you. Back to you, Makiba.
Thank you so much, Tina, for emphasizing the important role for data. Data, data, data. That's what I heard. We do have two more speakers and we're coming close to time. So we do ask that you would indulge us and stay a little bit longer so you can hear from some other speakers that we also have. So I want to hand over to Lucy Onyen. Hopefully I'm pronouncing that correctly. The clinical mental health counseling psychologist, chief of party USAID mental health integration activity and Strong Minds. So Lucy, over to you.
Good morning, good afternoon, and good evening. I feel privileged to speak at this amazing webinar. My name is Lucy Onen. I've been a practicing psychologist for some years now, and I work with Strong Minds Uganda as the chief of party for USAID mental health integration activity. And I'm happy to hear some of my colleagues talk about integration, and that is our niche. So Strong Minds Uganda started in 2013 with a specific target on treatment of women in low income countries. And now we are spread all over the world in one way or the other through partnerships with the national national bodies like the line ministries, but also with other development partners like the USAID partners. And we use a model called interpersonal psychotherapy for groups approved by World Health Organization, and it's delivered by lay people. I was happy to hear other people talk about trained lay people. And this year, we are going to celebrate 1 million people treated and with depression-free rate of 74%. That is sustained healing. So as we talk about maternal mental health, I would like to say that this presents in so many ways. It could be physical and emotional. And most importantly, in Uganda, we have seen the trend among adolescents. These are teenage mothers constituting 25% of the people treated. And these people struggle a lot with life transition as a new mother, and after the pregnancy, there is postpartum depression, which deprives them of proper attachment with the children, and some of these mothers become more suicidal. And so today, we have a lived experience, and in the person of Rebecca, who is going to share with us her life experience and the journey through recovery. So Rebecca, you're welcome. Thank you.
Okay, thank you. Good morning, good afternoon, good evening. I'm Rebecca Twazira. Boise. After completing school, I met my husband. Okay.
Just to confirm if
proceed.
you can hear us. Yeah?
Yes, you're
Yes,
loud
we
and
can hear
clear.
you.
Please go ahead.
Proceed. After completing my school, I met my husband, so we started staying together. I conceived. Then after conceiving, life was not hard because my pregnancy, it wasn't stable. So life started moving on not well. And I lost my baby. Then the life was not hard. I could not eat. I could not sleep. I was so sad. I even lost my job as a teacher because I could not attend the duty. Life was not hard. So the situation just worsened. But one day, one of the ladies in Stronger Mind, she's Madame Juliet, she came and visited me and she talked about that organization and she talked about the mental health and then depression. But according to what she spoke, as if she was talking about my situation. Because at first I was like, hey, this person. But at the end, I was like, let me join according to what I was going through. So I joined the group. We started meeting, we could meet, we could study, we could discuss the situation is. I heard from my fellow women. And from there, I got at least some encouragement from them according to their situation is. Because for them, it was worse. There was even a certain lady who had miscarriage of 4 pregnancies. But from there, remember, I could not eat, I could not sleep. But from there, according to the good words, the advice that was given to me, I started eating the favorite food that I could like. I could sleep well. I started even work. So I thank Stronger Mind. Every week that passed, I felt better starting discussing with people. I could isolate with many people. And then my life changed. I encourage my fellow women who are there, who are passing through such situation. I just encourage them that let them join Stronger Mind. Let them join. Because when I joined that group, my life changed. I started working. Then also I'm carrying a baby because at first I could not have that belief of getting pregnant, but I got it. I got the courage, and now I have a baby boy. So I sang Stronger Mind at large, and thank you for listening.
Thank you so much, Rebecca, for sharing your life experience. And this is typical of what women in Uganda undergo. And we are still a long way to support these women. So my final words to everyone is perinatal mental health is not an option, but it is a reality that requires collective responsibilities and action. I say this for God and my country. Thank you.
Thank you so, so much to Strong Minds and to Rebecca. And we know that there are many Rebeccas out there, each with similar and very different stories. I want to specifically thank Rebecca for being here this morning and sharing her story with us. I think it has motivated us as to the why we're doing this. So I want to leave you guys with a call to action. And we place the call to action in the chat. We want to integrate perinatal mental health in everything that we're doing. scale up our initiatives, and strengthen the skills that are and knowledge in the existing health workforce. Thank you all for staying a little bit longer so that we can hear from everyone with this webinar. Is such an important topic. We've tried our best to answer the questions that you've posed in the Q&A box. If we did not get an answer, we'll be sure to include that in the email that we will send out following with the recording and the slides and some links as well. So again, thank you to all our presenters and to everyone for joining us this morning. And we will see you all in our next GHC webinar. Thank you again.